Hi there. I'm Dr. Lauren Schur. I'm a psychiatry faculty member here at UC Davis in the Department of Psychiatry and Behavioral Sciences, and I'm here today to talk about what's often called as collaborative mental health care. So I am a hospital-based psychiatrist largely, so I do a lot of consult work, and I do consultations in the emergency departments and also in the medical and surgical floors here at the hospital at UC Davis. When I'm not doing that, I spend a significant amount of my time trying to improve mental health outcomes in the primary care setting. We have about 18 primary care clinics throughout the Sacramento area, and so when you hear the term collaborative mental health care, the goal is psychiatrists and primary care providers collaborating to improve mental health outcomes for our patients in primary care, and that's what we'll be talking about. So my goal for the next 10 minutes is to talk about how we have implemented collaborative care here at UC Davis. We're going to talk about briefly two pilot grants which led to the development of the Care Coordination Program. And as part of Care Coordination, we do a lot of depression care management, primary care provider education, PCP stands for primary care provider, and a number of electronic consultations and moving into virtual collaborative care. And we'll talk about what that means, as well as some new research and clinical implementation initiatives. So over the past 30 years, we have really seen that primary care has become what's known as the de facto mental health system. If you look at this slide, about 60% of patients with a mental illness receive no treatment at all. Of the 40% that do receive treatment, about half of them are from primary care providers, and the other half are from mental health professionals. So a patient with a mental illness, only 1 out of 10 patients with a mental illness will see a psychiatrist because there's a number of types of mental health professionals: psychiatrists, psychologists, licensed clinical social workers, marriage and family therapists, and a number of other types of therapists. There's a really big shortage of clinical psychiatrists, and there's a greater need to meet the patients where they are, which is often in the primary care setting. So there's a big need to help our primary care colleagues improve depression and anxiety outcomes in the primary care setting itself. And we'll talk about how we've done that. Another part of the problem is that 25 to 30% of primary care patients have a mental illness. If you talk to a primary care provider, they'll tell you a quarter of what I do is psychiatry. Also, only 50% of patients referred to specialty mental health actually follow through with making appointments. And there's a lot of reasons for that. Mental health care has largely been separated from medical care in the insurance system for quite some time. So if you are a depressed person and want to see a psychiatrist, you actually have to open up your wallet, call your insurance company and find out who the behavioral carve-out is, which is often a separate insurance company. It's much easier to get a referral to a cardiologist than a psychiatrist in our current payment system. So there's a big need to improve and integrate behavioral health into primary care. This is a brief review of a study that was recently published in the past 6 months looking at psychiatric comorbidity in 30-day all-cause medical readmissions. It was published in Psychiatric Services in April of 2015, looking at common reasons for patients being admitted to a medical hospital: heart failure, myocardial infarctions, and pneumonia. Very common reasons for patients being admitted to the medical facilities. For those patients who were also depressed, there was a very high all-cause rehospitalization rate as compared to the non-depressed patients. So this, along with other studies, has shown us that there's a significant need to improve behavioral health management on a population level for patients with depression. So what is that collaborative care model? I've mentioned it a few times. The collaborative care model is a type of integrated care. What you see there on your screen is really the old model. That's usual care, right? Primary care provider, that's the doctor and the patient. The patient's in the middle and the primary care provider on the outside. In the collaborative care model, you have what's called a care manager. That can be a social worker, like a licensed clinical social worker, or a nurse who provides in-person, in-clinic case management or telephonic case management, depending on the model, working with the patient and the primary care provider. And you also have a psychiatrist who meets regularly with the primary care providers and the social worker or nurse, and when needed for the sicker patients, can see the patients themselves. And so in effect, you have a number of providers working in tandem to help patients in the primary care setting. The collaborative care model also has very good evidence for efficacy. At this point, there's over 80 randomized controlled trials showing that if patient care is patient-centered, team-based, and collaborative, that patients will get better. And interestingly, the National Institute of Mental Health, the NIMH, no longer wants to fund collaborative care research because they know it works. The goal now, and what the NIMH wants, is to fund implementation studies to show that the research models can actually be exported into healthcare delivery systems. So it's time to put the research into practice, and that's what we've done here. So we've been doing this since 2011. We had 2 successful pilot programs, one in 2011 where we implemented depression care management in 2 clinics. We had improved depression scores, good patient and physician satisfaction scores, and replicated that in 3 clinics in 2012. After we had good outcomes and replicated those outcomes in 2012, the health system came to us and said, it's time to expand into the rest of the primary care network, and that helped develop what's known as the Care Coordination Program, which has a very large behavioral health component. So what did we do in depression care management? We had social worker and nurse care managers provide depression care management telephonically. Our primary outcome was looking at depression scores, and we looked at a validated measure called the PHQ-9, and the secondary outcomes were physician and patient satisfaction scores. What do we do? What does a collaborative care team actually do in practice? And so the first bullet's the care management team, and that consists of a psychiatrist, a nurse, and a social worker having a 2-hour weekly meeting talking about the panel of patients. The nurse and the social worker spend most of their time providing telephonic support with patients, helping them get connected to mental health professionals, providing education around depression management, anxiety disorder management, post-traumatic stress disorder, helping with management around issues related to diabetes and other modifiable cardiac risk factors that patients have. The second tier of the care coordination team in collaborative care is an education component, where myself and other psychiatry faculty members go out to all of the clinics and provide a curriculum on mental health to all of the primary care providers. We'll talk about basic psychopharmacology, medication management for depression, anxiety disorders, bipolar disorders, personality disorders, post-traumatic stress disorder, and other trauma-related illness. And we go out and build relationships with the primary care providers. We have about 140 primary care providers in our health system. The third part of our work is what we call e-consults, where a primary care provider, they're very busy, they're managing a lot of illness, diabetes, high blood pressure, heart disease, depression, anxiety. When they feel like they've done as much as they know how to do, they may order what's known as an e-consult and ask me through our electronic medical record, what do I do next here in terms of psychotherapy? Or what do I do next here in terms of medication management? Within a few days, they will have an answer from a psychiatrist. We're doing some more with telemedicine as well, which I'll mention at the end. So common referrals to the care coordination program includes diabetes management, referrals for weight loss, referrals for smoking cessation, and referrals for behavioral health, the most common being depression care management. As part of our team right now, we have 4 licensed clinical social workers. We have 5 nurses. We're about to hire 10 more health coaches that will be placed within the clinics themselves. We have 2 psychiatry faculty members who are involved. We also involve our fellow, who's a 5th-year psychiatry resident. We have pharmacists on staff, as well as healthcare navigators who help with referrals into the system. So a number of new initiatives in addition to the care coordination program. We have both research and clinical implementation grants. We have a very strong department in telemedicine and telepsychiatry. Dr. Peter Yellowlees has a large R01 grant comparing 2 types of telepsychiatry called synchronous and asynchronous telepsychiatry. We have implemented telemedicine in the Auburn Clinic, the J Street Clinic, the Folsom Clinic, and the Elk Grove Clinic. In the past 2 years, I received pilot funding to do clinical implementation of telepsychiatry in more of our clinics, and our goal is to scale up to the rest of the primary care network with hopefully a positive outcome in those clinics. We're also working with colleagues in the health system to expand e-consults across all of the clinics. We have an ADHD pilot project with one of our child psychiatry faculty, Dr. Murat Pakurak, to implement collaborative care for children targeting ADHD in one of the primary care network sites. And that's just a few examples of other initiatives done in the primary care network. Just a few things as a faculty member. I have close collaborators and mentors. Bridget Levitch is my partner in crime related to our work in developing the care coordination program. She's the director of the Department of Health Management and Education and is a big supporter of improving mental health outcomes in our primary care population. As a psychiatric educator and educator of medical students and nurses, my mentors are Hendry Ton and Mark Service. In the area of telemedicine and telepsychiatry, Peter Yellowlees is a close friend and mentor, and Dr. Robert Hales is my chair of the Department of Psychiatry and a big supporter. I want to thank everyone for your time and have a good day.